When I think about calcium, I know that I'm in for a battle. Calcium instantly makes any coronary intervention challenging, and as patients present with more diffuse disease than ever before and more calcified disease, everyone needs an algorithm that appropriately treats and modifies the calcium for better and longer-lasting revascularization results. Percutaneous coronary intervention of calcified disease is associated with lower procedural success and increased risk for both early and late complications because coronary calcification can impede stent delivery and deployment, lead to stent underexpansion and malapposition, and directly damage stents. Coronary artery calcium can be detected intraprocedurally by fluoroscopy, but this depends on the overall volume of calcium. Fluoroscopy alone lacks sufficient resolution to define the subtype of calcium. And so intravascular imaging improves the detection of calcium by further defining the calcium phenotype with the presence or absence of nodules, superficial or deep wall calcium, and measures the calcium extent. This is associated with improved clinical outcomes for patients undergoing complex PCI when used for PCI optimization. Intravascular imaging is in my treatment algorithm for all interventions, but is crucial in calcified lesions. If I am unable to deliver the image catheter, predilation with a smaller balloon or atherectomy may be necessary. Imaging criteria for calcium modification is based on calcium arc, length, and thickness, with recommendations for some form of modification for an arc of more than 270 degrees with a calcified length of more than 5 millimeters or thickness more than half a millimeter. Selection of appropriate modalities depends on patient and lesion characteristics. Frequently, predilating lesions with non-compliant balloons sufficiently prepares lesions and allows stent implantation to achieve an appropriate minimal stent area. However, in the setting of concentrically calcified lesions, there may be non-uniform balloon expansion, with underexpansion in the calcified segment compared to the edges of the lesion, commonly referred to as a dog bone appearance. This feature suggests that there's inadequate lesion preparation. Here, you can consider using cutting balloons, scoring balloons, or even high-pressure balloons. Atherectomy may best address long, diffusely calcified lesions or those uncrossable lesions. You can consider intravascular lithotripsy for concentric, eccentric, and even nodular lesions, and in the settings when atherectomy may be relatively contraindicated. Repeat intravascular imaging to assess for calcium fractures and/or perform a 1-to-1 size balloon angioplasty to assess for full expansion would be next. If these criteria are met, you can proceed with stent deployment. If, however, the initial calcium modification was suboptimal, undertaking further image-guiding calcium modification therapies prior to stent deployment would be best.